Well, hello again. Welcome to the AO Trauma North America Internet Pelvic and Acetabular Fracture Management course. This is week 6 of the course, and I'll be moderating today, David Stephen, on behalf of the co-chairs, Stephen Sims and Mark Reilly. This course is not to replace, but was thought up and made on the basis of the COVID pandemic. And unfortunately, we couldn't have the live event in May. It's been modeled after the other successful courses, specifically the osteotomy course that was just completed through AO North America. We hope to have a face-to-face course, cadaver course in Las Vegas. The tentative date is January 7 to 10, but that may be modified depending on the situation with regards to the COVID pandemic. All the lectures are recorded and CME has been offered, and you can view the lectures and the content on AO Trauma North America through the YouTube channel. One of the benefits of having this course is that we have no restrictions with regards to the faculty, and we've assembled the all-star cast of faculty members, most of which you've heard from, and if you haven't, you'll be hearing from in the coming remaining weeks. Today we'll be again talking about acetabular fracture management. We have Joel Williams from Chicago, Keith Mayo from Seattle, Mike Stover from Seattle, and John Eastman coming to us and talking to us today. These are the disclosures. Today's learning objectives, first is to understand the radiology, decision-making, and treatment of anterior wall, anterior column, anterior plus posterior hemi-transverse, and associated both column fractures. Next, we'll be talking from Dr. Stover are the indications, techniques, and potential complications of the extended iliofemoral approach. And then finally, Dr. Eastman will be talking to us about management principles for concurrent pelvic ring and acetabular fractures. This is the outline today. Dr. Williams, myself, Dr. Mayo, Dr. Stover, and Dr. Eastman. Your microphones have been turned off, and your video has been turned off. Please use the Q&A for questions, not the chat button, and we'll get to as many questions as possible. And when there are certain questions that are directed specifically to the faculty, we'll hopefully have them answer. There may be some questions that are appropriate for discussion with the larger group. So with that in mind, I'll hand over to Dr. Williams with regards to the first talk, which will be anterior wall and anterior column fractures, radiology, decision-making, and treatment. Joel, looks good.
Thanks for the introduction, DS. So in the next 15 minutes, we're going to be talking about anterior wall and anterior column fractures. I have no disclosures to report, and I'd like to give a special thanks to Drs. Ferguson, Stephen, and Rothberg for contributing slides and cases. The outline we're going to get through is here. We're going to start with the anatomy, classification, pathomechanics, and epidemiology. And really the bulk of the talk is, I think, what everybody wants to hear about, which is assessment and treatment. We've seen this slide or a variant of it a couple of times. The inverted Y concept was first described by Judet and Letradel, and the anterior column is the area in red, the posterior column is the area in gray, and they support this 300-degree arc of articular cartilage. So this talk is going to be focused on the area shaded in purple on the left. Those are anterior column fractures, and then sort of its close cousin or almost subsect of fractures of the anterior column are anterior wall fractures, which are a specific entity. We're going to show that throughout this talk. Anterior column fractures can be further subdivided into high, intermediate, and low. And that distinction is based upon where the cranial extent of the fracture exits. So high fractures exit along the wing or the crest, posterior to ASIS. Intermediate fractures exit between the superior spine and the inferior spine. Low and very low fractures exit below the inferior spine. And at a glance, it looks very similar to the anterior wall fracture, which is over on the right. But the anterior wall is distinct from the anterior column in that there's a double disruption or a segmental fracture of the pelvic brim. And on the radiograph, as we'll see in a moment, it'll be a disruption in 2 places of the iliopectineal line. So here it is. This is a sort of classic view, sort of somewhere between an AP and an obturator oblique view. And you can see this fracture fragment outlined with the dotted line. That's a classic look for an anterior wall fracture. The term anterior wall, I think, is very overutilized. The common imitators, and I think probably the most common misuse of the term, I think happens when a patient comes out of the CT scanner and the report's read by the radiologist. And something like this is called an anterior wall fracture, when in reality it's a pubic root or superior ramus fracture. Another sort of less common imitator, but easily confused entity is a very cranial or anterior posterior wall or posterior rim fracture. Because this fracture does not disrupt the iliopectineal line or the pelvic brim, this is a posterior wall fracture, not an anterior wall fracture. These fractures occur with a fall and the force placed upon the greater trochanter with the hip and external rotation. In theory, more external rotation makes a wall fracture more likely, and less external rotation makes a column fracture more likely. In the original series by Judet and Latrenelle, these are very, very uncommon entities, at least in their elementary patterns. As we're going to hear about later today, the associated patterns, which have an anterior wall or anterior component, are much more common. But the pure anterior columns in their series were less than 5%, and that's all different subtypes. Anterior walls were even less common, and they represent less than 2%. Imaging, of course, starts with radiographs, and in the modern era, I think CT scans are standard of care. The reformats, the two-dimensional, all the two-dimensional ones, I think are crucial to study before bringing a patient to the operating room, and even before jumping straight to the three-dimensional reconstruction. You can make out fracture lines, areas of comminution, areas of impaction. So just to review, on the EP pelvis radiograph, there's the iliopectineal, iliischial, anterior rim, posterior rim, sourceal, and the teardrop. Here's an example of a high anterior column fracture, and you can make out that sometimes it's rather subtle when you see a fracture like this. There's definitely a disruption of the iliopectineal line. The sourceal appears slightly tilted, but overall it does not look grossly different than the other side. The teardrop is variably involved depending on the posterior extent of the fracture line, but the posterior rim and the ilioischial line, by definition, are intact if it's an elementary anterior column fracture. Judet views are, of course, important, whether your preference or your institutional protocol is plain film radiographs or digital reconstructions is subject for another talk, but I think it is important information to gather in some form. The classic structures that can be visualized on the iliac oblique are the posterior column and the anterior wall, but of course we can see much more. Starting at the top left and working our way around counterclockwise, you can see the superior spine, inferior spine, the pubic root and spine. If you look way down at the bottom, you can see the symphysis. And then starting at the bottom red square, you can see the lesser sciatic notch, the ischial spine, the greater notch, and the posterior superior iliac spine. This is an example of somebody with an anterior column fracture visualized on the iliac oblique. The area in blue is the displaced articular segment, and the area in red is the intact articular segment. The obturator oblique classically is used to visualize the anterior column and posterior wall. But of course, again, we can see so much more information on this normal radiograph. We start at the top left and work our way around counterclockwise. Again, you can see the radiological roof, the posterior border and posterior articular surface of the bone. You can see the pelvic brim. You can see the articular surfaces, including the SI joint quite well, and the sacral ala. Here's an example of an iliac oblique, an obturator oblique view in a patient that has an anterior column fracture. The blue area, and it corresponds to the image of the top right, which is an axial CT cut, corresponds with the intact portion of the articular surface. The red is the displaced anterior column component, and the yellow is the area of articular impaction into the intact ilium. And again, this is probably the best view if you've identified there's a disruption of the iliopectineal line, you're thinking that your diagnosis is anterior column or anterior wall. Look at the obturator oblique. If there's a double disruption in this trapezoidal shape, it's an anterior wall. If there's a single disruption, or sometimes there's not even a disruption until way down inferior, close to the symphysis, then it's an anterior column. We heard some excellent talks last week going over step-by-step approaches. I think all of the anterior approaches and all the approaches, for that matter, to treat acetabular fractures are worth understanding and committing to put into your toolbox. When I'm looking at a fracture and deciding which windows or which approach I want to utilize, I feel that if there's a fracture that I need to work on and look at the pectineal eminence or very close to it, especially if I want a clamp application on the pectineal eminence, the middle window offers the best access. When thinking about treating these injuries, the high and intermediate columns follow a similar strategy, and we'll go through some cases to illustrate them. So here again is the high anterior column fracture we saw a moment ago. In some representative CT cuts, as we get closer to the joint, you can make out the primary fracture line is rather horizontal, which is typical of anterior column fractures. There's some comminution of the iliac wing. Here's our first cut through the joint with displacement of the anterior column component. And now we start to think about how we're going to fix this. I think conceptually, the sequence is rather straightforward. It's reconstruct the wing, then reconstruct the articular segment. But like anything, the devil's in the details. So some of the important considerations and things that you need to have in your preoperative plan are situations if there's an incomplete fracture, for example, which means there's displacement at the joint, but as the fracture line exits or ascends the ilium, it doesn't, there's no displacement or it's an incomplete fracture line. So in situations like that, sometimes if you're struggling to mobilize the articular segment, you may need to complete the fracture so you can fully mobilize the articular segment to get a proper reduction. When we get a reduction and we start thinking about fixation, are screws alone appropriate? Or if you're going to use a plate, what's its function going to be? Neutralization or buttress? Areas of impaction, of course, for all articular injuries are important to address, but with these fractures in particular, when to address them. So we're going to see one method in this talk, and then Dr. Stevens is going to talk about a second option. And of course, the quadrilateral plate in some fractures is important. When to buttress it, when you can leave it alone is an important consideration. So on a sawbone model, this is what a reduction sequence looks like. This is a high anterior column fracture with a sort of pie-shaped area of comminution of the iliac wing. The first step is to reduce the wing to the intact ilium. As shown here, these drills can be preloaded, so once you obtain a reduction, they can be sent across and used as provisional fixation, but then removed one at a time and screws put in. Here's an example of clamp application to get a reduction of the iliac wing. If you look closely at the top right image where the arrow is, there's a malreduction on the outer table of the ilium. And it's critical that you don't do that. You know, there's a reduction which is going to be first obtained at the crest. If you have any malreduction with your first step, it's going to be propagated and accentuated or exaggerated as you move along throughout your reduction sequence, and you're going to end up with an articular malreduction, which is what you absolutely don't want. So here's the clamp again. A Farabuff clamp is used to assist with the reduction. Drills are sent across, lag screws are then placed. We then reduce the anterior column to the intact ilium. Drills are again preloaded, and either a shank pin and or clamp can be used to obtain this reduction. The drills are then sent across, and typically lag screws are placed. To reduce the articular surface to the ischial segment or the posterior column segment inferiorly, a pointed reduction clamp can be used like this, through the stoppa or AIP window, or an ankle jaw clamp can be used like this through the middle window. Once we have a satisfactory reduction with clamps or buttress plate, or however you've obtained your reduction, independent lag screws are typically placed. These arrows represent screw opportunities, not necessarily the exact construct you need to have every single time. So again, here's an example of the lag screws placed in the iliac wing. More lag screws from anterior to posterior, one from cranial to caudal, and then this plate can be applied with screws to neutralize this construct. Here's a final radiograph of the that same patient. So case 2, this is a patient that Dr. Rothberg took care of. It's also a high anterior column fracture. Here representative digital Judet reconstructions showing a high, probably incomplete anterior column fracture on the obturator oblique, on the iliac oblique. And if you look at the image on the right, there's a contralateral extra-articular ilium fracture, which was treated non-operatively. So this was approached through a lateral window with the buttress plate starting at the top left, and then a lag screw inserted to compress the fracture. So the previous slides with the sawbone represent all the screw opportunities, but you don't necessarily need to place every single one in every patient. They're definitely fracture specific and patient specific. Here are the final radiographs of that patient. Moving further down, the treatment strategy for anterior wall and low anterior column fractures is somewhat similar, but a bit different. I think it's first important to realize that bone quality is absolutely going to be an issue in most of these patients because they're much more common elderly fracture patterns. And as such, some of the common features that will be present include impaction or sourceal displacement. Oftentimes the femoral head has a central dislocation or subluxation, and there's often a quadrilateral plate component. Here's a very typical example of this elderly anterior wall fracture pattern. If we look to the CT scan, we can make out the anterior wall on top, and then if we look medially, there's a quadrilateral plate component. Here's a sawbone representation of the anterior wall fracture pattern. The area outlined on the pelvic rim is the anterior wall component. This is the quadrilateral plate component, and if it involves a significant portion of the articular surface, I think it's important to address. Or if it's going to help with joint congruency, it's important to address. If either of those are not true, then this fragment of bone doesn't necessarily need to be incorporated into your fixation construct. This is the area that you have to look for on the CT scan. If you don't identify it, it won't become evident until you have a malreduction when you're operating on the patient. This is the area of impaction into the intact portion of the articular surface. So the sequence for these fractures is typically to lateralize the femur, reduce the roof, and there are two images or two methods at the image at the top right. One is to access the roof or the articular displacement through the fracture, and the other is to make a cortical window, and Dr. Stevens is going to talk more about that technique. Once the roof is reduced, it needs to be rafted. Sometimes bone void filler can be utilized. Then the wall is reduced, and then the quadrilateral plates can be reduced if necessary. So schematically, it looks like this. The femoral head is lateralized. The roof is reduced to the head, and then rafting screws are placed. Fluoroscopically, this is what it looks like. The Lambot osteotome is inserted through the AIP window, and the bone tap is inserted through the middle window. The roof is reduced, rafted initially with K-wires, and then rafted with independent screws. In this fracture, the quadrilateral plate was deemed necessary to fix. So there's a buttress plate applied, and then a secondary buttress plate for the anterior wall component along the pelvic brim. Here are the final radiographs for that patient. And last case, this is a very unique injury that Dr. Stevens took care of. On the AP radiograph, you can make out the femoral head is subluxated or dislocated. The sourceal is involved. There's a disruption of the iliopectineal line, and there's something going on laterally near the inferior spine. The Judet views really help with this. If you look at the image on the right, you can see two disruptions of the iliopectineal line, which means anterior wall. But also, if you look at the iliac oblique, you see a separate fragment, which on the CT scan is a separate posterior wall that's very cranial and very anterior. This is a three-dimensional CT video of that fracture. And it was treated with 2 pelvic reconstruction plates in buttress mode for the anterior wall component. You can see that nicely on the image on the right, which is the iliac oblique. And then spring plates were used to capture the posterior wall fragment, which you can also see on the iliac oblique, and you can see nicely on the AP and obturator as well. This was done through a Smith-Peterson approach. So in summary, we started with the anatomy, classification, pathomechanics, and epidemiology, and then moved on to assessment and treatment. I think just keeping in mind the double disruption trapezoidal shape, look for it on the obturator oblique to discern the anterior wall from the anterior column fracture patterns. And then some of the treatment principles that I'd like to sort of summarize is the middle window is essential when you're working on the pectineal eminence. And for a lot of these fracture patterns, you need that access. The construct is fracture specific and patient specific, includes lag neutralization plates and buttress plates. Impaction is important to address. We saw one way to do it, and Dr. Stevens is going to show us a second way.
Dave, I could ask a question of Joel if you like.
Yeah, great.
Joel, there was a question that came up, and this will come up, I'm sure, in the both column talk as well. But the question was if you felt like in that example you showed, if you felt like reducing the joint is the critical part, that pie-shaped piece, why did you reduce the pie-shaped piece first? Maybe you could clarify that for people.
Yeah, absolutely. It's a great question. I think if there's a lot of comminution and that first step is not going to help you with the articular reduction, you don't necessarily need to start there. But I think in a fracture pattern where there's a relatively clean fracture line with minimal comminution, reducing the crest or the wing first is going to help you indirectly reduce the articular component. So I think for a lot of especially the high anterior column fractures, it makes sense to do it that way. But absolutely, if there's a much smaller piece that's comminuted and you're going to strip it like crazy, and it's going to be a struggle to get it reduced, I don't necessarily think you need to do it every time.
So I guess the point is that you can only see a very small part of the fracture line below that pie-shaped piece, so your ability to accurately reduce it may not be so good. But if you can reduce that pie-shaped piece, you have a nice long fracture line to help you reduce the articular portion of the anterior column back to that, and it gives you a lot better read for your final reduction. Is that kind of what you're saying, I think, isn't it?
Yes, absolutely. Said much better. Thanks.
Okay, I'll carry on now. And this is a continuation of Joel's talk, which was excellent. And there'll be a little bit of overlap here. So I've been asked to talk about the anterior wall / column plus posterior hemi-transverse fractures. So the objectives here are to talk about the radiology, decision-making, and some treatment ideas. Now, this is in chapter 13 of Litchinell's textbook. And in his series, the percentage of this subtype was 6.58%. And our experience at our institution at Sunnybrook, we're seeing more and more of these variants and combined with the anterior column wall as people stay more active into their older years. The primary fracture line is the anterior wall and/or column, as you can see here schematically. Here's the anterior wall drawn out. And then the secondary fracture line is the posterior column, coming at an angle approximately 90 degrees from the anterior column fracture. Now, if we go through the radiographic features, for the most of these types, 5 out of the 6 lines will be involved. The posterior rim or wall will not be involved, but the iliopectineal line will be disrupted here because you have involvement of the anterior wall / column. The teardrop and the anterior rim are involved as you get medialization of those findings with displacement of the anterior wall or column. Now, the ilioischial line can be disrupted, and as we heard from Dr. Sims a couple of weeks ago, this can be simply involvement of the quadrilateral surface, as you heard from Joel. Even in an anterior column, you can have involvement of the quadrilateral surface, which can disrupt your ilioischial line, or it can be involvement of the posterior column and rotation medially of the quadrilateral surface as it is attached to the posterior column. The distinction, as we'll hear from Dr. Mayo with regards to the associated both column, is there is a segment of the roof that is intact in the anterior column wall posterior hemi-transverse. And then medially, this can be impaction, but most commonly, this is rotation of the component of the anterior column, and we'll go through that a little more detail in the coming slides. With regards to the posterior column, it's at variable location, but it's often low at the area of the ischial spine, and it's usually minimally displaced, but in some variants, as I'll show, it can be significantly displaced. If we look at the Judet views, on the obturator oblique view, again, you can see that segment of the acetabular roof intact in this case. You can see rotation and displacement of the anterior column, which is hinged on the upper segment of the pubic rami in this situation, and medialization of the head, and then that fracture of the posterior column as it exits. Now, if you have a lower posterior column, it can actually bisect or transect the teardrop and disrupt that more completely. Now, there is a fracture of the inferior pubic rami in this case, and you can say, well, why isn't this a T-type or a T-shaped fracture? And we'll go through that in a couple of slides, the distinction between the two, as Dr. Reilly pointed out last week in his talk with regards to the T-shape. On the iliac oblique, again, you can see that intact portion of the acetabular roof. You can see rotation or involvement of the quadrilateral surface with attachment to the posterior column. And then you can see, again, that exit more cranially, if you will, of the posterior column. And again, in this situation, that true impaction that will delineate more with the CT scan. Now, if we go through the axial cuts, and this is a situation where I put up 6 cuts here, but you really need to study this more precisely. But one of the benefits here, or one of the keys here, is to actually put the cursor, in this case I put a star, on the intact portion of the acetabulum, if you will. And then just as you scroll down through the cuts, keeping in mind, and this is the intact portion, which makes it different and distinct from the associated both column. But what you can see here is anteriorly is that involvement of the anterior column, the low anterior column, as it extends down, just in this region here, as it starts in the region of the anterior inferior spine, the top, and rotation. And that was what we thought was impaction, but in fact, that's rotation of that anterior wall as it rotates cranially and medially. And again, here's the segment as it bisects the articular surface anteriorly, just as you follow it down. And then you can see involvement of the quadrilateral surface just in this area, and the vertical fracture line that is the posterior column involvement, making it an anterior column, a low anterior column, and a posterior hemi-transverse with involvement of the quadrilateral surface and some impaction, which is most commonly posterior superiorly, and then the more caudal cuts showing again rotation of the quadrilateral surface. It probably has an incomplete fracture line just in this area as it joins up with the posterior column. Now, if we go right to the 3D scans, and again, I think as Joel pointed out, studying the 2D reconstructions, and we'll show this in a couple of cases, is very important to delineate where the impaction is. But again, on these 3D cuts, you can see the intact portion of the acetabular roof. You can see the segmental, or what Letournel calls the trapezoid nature of the anterior wall / column. And then again, seen on the oblique projection, rotation of the quadrilateral surface. And you can see just in this area, the exit of the posterior hemi-transverse. And this correlates here to this axial cut just shown here. And then if we do a 3D projection, more the iliac oblique, if you will, you can see the exit of the posterior column a little higher than in some variants. And then again, the intact acetabular roof. And again, correlation to the axial cuts, you can see again that this is the exit of the posterior column, and where the star is essentially that intact acetabular roof. So as Dr. Reilly pointed out last week, comparison to the T-shape, The T-shape has a fairly characteristic pattern, but the distinction here is that trapezoid or segmental nature of the anterior wall of the column. There's still of that involvement of the posterior column and basically 90-degree projection into the posterior column from that anterior involvement. And again, if we look at the 3D scans, again, a fairly characteristic pattern for the T-shape, which exits more vertically. You can see again that it does exit. This is the anterior column, posterior transverse of another case we'll come to in a second. That exit can occur in the through the obturator foramen, but it tends to be more anterior. And again, you can see on this projection coming more along the anterior column. And this is the exit again of the posterior column. So you can see that there's kind of a transition almost, but the key distinction is this segmental nature of the anterior column wall. And again, showing that more anterior, if you will, exit of that fracture line. One of the keys also is displacement of the femoral head. In the T-shaped fracture, as shown here, the femoral head tends to follow the posterior column as compared to the anterior wall posterior transverse, which the femoral head will follow the anterior wall column as shown on the right. The comparison to the associated both column, again, as you'll hear from Dr. Mayo, in the associated both column, shown on the right here, there is no remaining attachment of the acetabular roof or joint surface to the intact ilium, as compared to the anterior column posterior transverse, where you have a small or variable portion size attached to the intact ilium. And so if we look at the images just of an anterior column posterior transverse superiorly there, you can see again in this case there's a portion of the acetabular roof that is intact and attached to the intact ilium, as compared to the associated both column, where there is no remaining joint surface attached to the intact pelvis, and this showing the spur sign, which again you'll hear from Dr. Mayo in a few minutes. The variables, they can be many with regards to the fracture lines, but also there can be significant impaction, as Joel alluded to in his talk. Usually this is posterior superior, so here is the 2D reconstruction both in the sagittal and coronal. So there can be true impaction in this situation, and it's important to delineate this and also quantify it on your plane films, which are important in the operating room that we'll see in a couple of seconds. And here's the 3D with the head subtracted in this case, and you can see that posterior superior impaction. As I've mentioned, there can be quadrilateral plate involvement. This can be separate or attached to the posterior column, and it can be highly comminuted as well. With regards to the posterior column, again, it can be minimally displaced, or in this situation, you can see a fairly significant displacement of that posterior column exit fracture. And this is just a 3D correlate. The treatment options range from non-operative to open reduction internal fixation, and that's usually the default, that's internal fixation. In a small percentage, you may consider a primary total hip either with or without open reduction internal fixation of the anterior column. What goes into the decision making? Well, there's obviously many factors, and that includes the patient factors and also surgeon factors, but also the fracture characteristics. And we know from many studies, and those from Luternell and Joel Matta and others, that there are significant risk factors for poor results in all acetabular fractures, and this subtype is no exception. Age greater than 60 and a little lower in Matta series, and again, that's probably physiologic age as opposed to chronologic age. But the two things that we're dealing with here with this subtype are acetabular impaction with free interarticular fragments, whether there's febrile head involvement. So that's where it really comes in and becomes key, studying the images and also knowledge of the patient factors. Just a word about non-operative treatment. This is very rare, and this was a study out of shock trauma a couple of years ago, and over an 11-year period, they treated 26 cases, and it can be treated. And very, very rarely in our institution, when patients are virtually a medical contraindication of surgery, we may consider this. More commonly, we're thinking about individuals that have perhaps older population that can only withstand one operation. They have medical issues, and this is one case where the patient had medical issues, they had impaction, femoral head problems on the imaging, and they had pre-existing arthritis. And you'll hear more for this from Dr. Creeder in 2 weeks with regards to this treatment strategy for these individuals. As mentioned, the default is internal fixation. I think first is key is consultation. So with your colleagues, deciding on those patients that may fall into the category of total hip arthroplasty, but I think for the vast majority, you're looking at internal fixation. We talked a little bit about tables last week. In our institution, we use both. We tend to use more radiolucent table depending on how much help we have. The benefit of that, as you heard last week, is that you can flex the hip. And when these fractures are very low, you really need to have access. And unfortunately, the fractures often become right behind the psoas. And so you'll need to add not only the ilioinguinal, but the anterior interpelvic approach as well. In certain subtypes, and I'll show a case of this, you may consider an additional posterior approach. But I think for reduction, I think as Joel mentioned, repositioning the femoral head is key. So lateral and distal traction. And then the buttress plates for the column and consideration of the quadrilateral surface. And finally, quantifying and dealing with the impaction. So here's a case. This is a 70-year-old falling off a bike. And again, you can see the characteristic rotation of the anterior column and that double density. And that may be the anterior column, but most likely that's involvement of the ilioischial line as it rotates medially. And it may or may not be attached to the posterior column. There's our intact acetabular roof. That's likely rotation of the low anterior column wall, and then the exit of the posterior column fracture on the AP. If we look at the iliac oblique, again, there's true impaction now, just in that posterior superior area that we've talked about. There's rotation and displacement of the posterior column, and there's the intact acetabular roof as seen. There's no extension into the iliac wing. So this would be a low anterior column, if not a wall. And then on the obturator oblique, you can see involvement of the anterior column. And then on the CT scan, as you go through the axial cuts, you can again see the fairly low anterior wall. You can see in this region the impaction, that double density that you see, and then some comminution. So you know right away there's some comminution at the brim and into the quadrilateral surface. You can see the exit, in this case, of the posterior wall. There's the impaction. And then we follow that down more caudally, and you can see again the exit of the posterior column fracture. If we look at the 2D reconstruction, the sagittal and coronal, you can again see the impaction, the true impaction in that posterior superior area. Now we had a request from the participants to look at the video from Dr. Reilly and Ferguson about drawing the fracture. I'm going to take a crack at it here just for the sake of time. I'll go through this fairly quickly, but one of the nice things on the axial is to quantify, get landmarks. So here I've just put a star in the anterior inferior spine, and this correlates to this dry erase pelvis, which I think is very valuable when you start to draw these. You can erase your mistakes. And we start making, as you can see here, that anterior wall starts just in the region, just a little bit caudal to the anterior inferior spine. And then as we follow down on the cuts, and you obviously want to have more of these cuts up as you start to draw it. But as mentioned in the video, you start making dots on where these fractures exit. I've made them fairly large here just for the sake of being able to see them. And then you connect these dots, and this comes up with our low anterior wall low anterior column. You can see just in this region, there's some comminution along the brim. So there's something going on. I'll just mark it in there on our brim area. And then there's the impaction, as I mentioned, and this is in the posterior superior area. And if you follow the cuts down, you can sort of get an idea and guesstimate, if you will, or estimate where that impaction occurs. And then exit of that posterior column component of the anterior column posterior hemi-transverse, which this would constitute. Now, if we look at the exit along the quadrilateral surface, again, here's our low anterior column, our involvement in the quadrilateral surface / brim, just along here, and here's our exit in through the greater sciatic notch of that posterior column extension. If we turn the dry erase over, again, using the anterior inferior spine as our landmark, we know that that posterior column fracture line is just a little caudal to that, so it's exiting probably a little lower than that, but in the region of the greater sciatic notch, just in this region. So then we can go to the 3D correlates and see how we did. So again, we see that impaction, we see this segmental, the segmental nature of that low anterior column, just in this region, and that exit of the posterior column. into the greater sciatic notch area. So the surgical tactic for this will be positioning. In this situation, it's supine. And as Dr. Saji pointed out last week, that if you anticipate going through the anterior intrapelvic window, you don't want to bump the patient up. That will actually encourage the femoral head to go more medial. You want to approach this through an ilioinguinal approach. In this situation, we added the AIP window, or the fourth window. Again, reduction of the femoral head with inline traction. In this situation, we did it on the radiolucent table with inline traction and then lateral traction of the femoral head. Initially, it's going to be anterior wallum and column exposure and stabilization, as Joel talked about, initially with temporization with K-wires. And if the fracture is high enough, such as in an anterior column, as Joel showed, you may consider lag screws. In this situation, it's fairly low. So it's going to be very close to the joint, and you won't be able to get lag screws in this situation. You want to address the impaction, and again, buttress the anterior column, rafting screws for that disimpacted impaction, and then consideration about the quadrilateral surface. So here we are here. We want to reduce this. And again, Dr. Mayo will go through this. This clamp is placed, this is a little higher. This is just schematic, but you can use clamps, as Joel pointed out, just to reduce this. Often when it's low, you're using a spike ball pusher. And then in this situation, as shown, you're using a temporization with K-wires, and you can see the femoral head's been repositioned, and just showing the oblique views just to reestablish the anterior wall / column. Next would be assessment of the impaction, and that's why it's so important, in my opinion, to quantify this impaction on the plain film Judet views. So you can see in this situation, just on the oblique view intraoperative, you can see the asymmetry in that impaction of the joint surface. And so as Joel pointed out, this is taken again from a schematic. You can work through the fracture, but in this situation, we've already reduced the anterior wall. You can also access it through the AIP window. If you have comminution, you're able to rotate that quadrilateral surface, and within inline traction, you may be directly able to visualize that impaction of the articular surface. In this situation, we used intraoperative imaging in addition to that window through the quadrilateral surface. And then just a schematic. So we're localizing that impaction with a K-wire under fluoroscopic control. We're following it down. You can see just in this area where I've just drawn this out, where that impaction is seen on the radiograph. So you're using biplanar or multiple oblique views, both on the obturator oblique and the iliac oblique, to quantify where that impaction is. And then you can use either cannulated, or in this situation, these are solid exchangeable punches. So we make a window using a 1/4 inch osteotome where the K-wire was. And then we use our punch as we would, such as a tibial plateau, to follow this down and quantify where it is on the iliac oblique imaging. You can see a spike ball pusher holding the anterior column in place. We've got our K-wires loaded, ready to go. And you can see congruency as best we can tell on the imaging, but also what we've been able to do is visualize this directly through the AIP window to assess the disimpaction of the impacted articular surface. And then we impact the subchondral wires across this surface as a rafting technique. The next thing is going to be placing the anterior column plate, as shown by Dr. Williams. And again, this can be variable length in this situation, and we want to stabilize it proximally and distally. And then we're slowly replacing and buttressing that anterior column wall, and then replacing our K-wires. Now, with reduction of the quadrilateral surface posterior column, again, Dr. Mayo will talk about this in his talk. This is an offset clamp, and where is this placed? Generally around the region of the anterior inferior spine. Now you can work lateral through your lateral window, lateral to the psoas, or you can work across and through both the lateral window and the middle window. This depends a bit on how big that psoas is. You have to run the risk of crushing that psoas, and obviously the femoral nerves in that area. So again, if you do this on the fracture table, you'll tend to not be able to flex as much, and you'll have to work through both the lateral and middle window. If you're able to flex up a little bit more, such as in a radiolucent table, you can work lateral to the psoas and down through the brim. So this is just showing the clamp placement for the posterior column, as Dr. Mayo will also deal with. This is a disc, so it can distribute the forces in the anterior, in the quadrilateral surface. I would encourage you, when you do this, to place a suture on that disc, just in case the disc becomes dislodged from the clamp itself. And then we're just modifying and assessing our reduction. You can see there's an imperfect reduction of that posterior column, and we've modified this clamp on several occasions to try and improve the position. And then we're working through the plate to get both posterior column fixation. We're also buttressing as we compress that screw down on the anterior column to act as a buttress of the anterior column component. And thirdly, we're also placing screws fairly subchondral, so we're rafting that disimpacted portion of the articular surface. You can see that screw close to the joint is larger caliber from the 3.5 in this. That's a 4.0 cortical screw to add some increased fixation in this fairly osteopenic situation. And finally, we're placing a screw from the anterior inferior spine across a subchondral to act as a secondary buttress or rafter, if you will, of that subchondral surface. And this is just showing the final construct. You can see slightly imperfect reduction of the posterior column. One of the things that also comes up is this so-called, some people call this the quote-unquote Lutrinell screw, as it comes between the articular surface and the obturator foramen. You can see the trajectory of this, and this adds fixation in an osteopenic situation between the anterior and posterior columns into that, anchoring in that strong bone in the ischium. And this is a different case, just showing where the trajectory of that screw is in the obturator oblique view. And intraoperatively, generally, you're doing an obturator view to place that screw safely, usually through the middle window of the ilioinguinal. What about if you have residual displacement of the posterior column, or you're unhappy with the reduction? Then you may have to consider, much like Dr. Reilly mentioned last week with the T-shape, you may have to consider doing a sequential approach, taking the fixation out of the posterior column, and then doing a sequential posterior approach to reduce that posterior column. So if you have displacement of the posterior column, you may need to develop that towards the notch, as Dr. Sadji pointed out last week, to allow clamp placement onto the posterior column. You may plan a sequential posterior approach, and I'll show a case of that in a second. Or there may be an incomplete reduction where you may need to remove the fixation for the posterior column and again, ensure that that impaction is stabilized, but then do a sequential posterior approach. And this is a case from Dr. Reilly, quite dramatic displacement and dislocation of the femoral head. This is the reduction, and I'll go through these fairly quickly. Again, the characteristics of an anterior column, anterior wall, posterior hemi-transverse. You can see significant displacement of that posterior column initially, just shown here on the 3D views. And the plan here, based on the interpretation, was to start with a Coker-Langenbeck to fix the posterior hemi-transverse. Sequentially, you can see fixation again of the displaced greater trochanter fracture, and then do a sequential ilioinguinal with sequential fixation that we've talked about. You can see the mini fragment plate for a multi-fragmentary anterior wall. And this is shown at approximately 9 months postoperatively with a good radiographic outcome. Lastly, what about a comminuted quadrilateral surface with impaction? And I think Joel alluded to this. It's often a dilemma whether you need to place a quadrilateral plate surface, but for me, if I have impaction and I want to really contain the femoral head and deal with the impaction, that's when I'm starting to think about a quadrilateral surface plate. Again, the characteristics of an anterior column, posterior hemi-transverse, comminuted quadrilateral surface, which are separate from the posterior column. And this is really transitional. You can say that this may be representative of an anterior column. In Lutrinell series, he had a series of incomplete posterior column involvement in the anterior posterior hemi-transverse, and this is probably a variant of that. And again, just showing an ilioinguinal approach with a fourth window, disimpaction of the articular surface, and then sequential fixation with subchondral rafters. And because of the degree of comminution of the quadrilateral surface, I felt that it was important to contain the impaction and the femoral head with a quadrilateral surface plate. And how do you do that? Well, this is through the AIP window. Generally, I use a 4 to 5 hole plate. And obviously, as you get closer, just in this region, we know the margin of the joint surface is between the anterior inferior spine and the iliopectineal eminence. So these two screws will not be available for screws. This screw, the third screw here, is very close to the joint surface, and you'll have to direct that more cranially, and you'll need radiographic assistance to assure you're not outside the joint. Sometimes you'll need to follow that plate down all the way down to the brim, and that can be useful as well to gain added fixation. The anchor screw is just up in the sciatic buttress. That's generally the first screw I put in this region. You have to be cognizant, as Dr. Saji pointed out, for the neurovascular structures in this region. I'm just showing the sawbone schematic. Now you can also use the pre-contour plates that have more involvement and buttressing just in this region that are available commercially. And this is just showing intraoperatively, just showing the combination of the subchondral rafting screws going through the anterior column plate and then the secondary quadrilateral surface plate. And this is this case at 2 years. So in summary, we've gone through the radiology with the 5 out of the 6 lines disrupted. The iliopectineal line will be disrupted and the femoral head displaces with the anterior fragment. The ilioischial line is often disrupted, and that can just simply be quadrilateral surface involvement with or without detachment from the posterior column, or in fact, it can be displacement of the posterior column itself. Remember that a portion of the roof is intact, as in contrast to the associated both column, and there can be a degree of impaction, which is usually posterior superior, but the impaction often we think is seen on the AP is usually just rotation of the anterior wall column. Finally, the teardrop and the anterior wall are involved. They're usually medialized. And it's important to quantify that impaction on the 2D reconstruction and the 3D radiographs. With regards to decision-making, the default will be internal fixation through the ilioinguinal with or without the AIP extension. The key is repositioning the femoral head laterally and distally. The operative techniques include impaction, and as mentioned, and as built on from Dr. Williams' talk, is buttressing the anterior wall column. With regards to the impaction, you can do that either directly through the window, directly through the AIP approach, or indirectly through a window in the iliac fossa. And it's important to buttress this with subchondral screws and with a plate in addition to the anterior wall with regards to the quadrilateral surface. And finally, reduction of the posterior column is important, and often that is done through the anterior approach, but you may require an additional approach through a posterior approach. Finally, I would encourage you to concentrate on these subtypes, and this is just showing that the real key, I think, to all of these injuries is through the Lotrinel textbook. So at that point, I'm going to stop sharing, and I'll hand this over to Dr. Mayo. Thank you for your attention.
Okay, so welcome, and you've seen 2 excellent talks covering a tremendous amount of territory this morning, and now I'm going to try to include in one talk, actually 3 separate topics. I'm going to briefly review the radiology, talk about approach choice again, since we really haven't had much choice in the previous 2 segments, and then very briefly some technical aspects. So we're going to go over the fracture morphology and imaging briefly, then a focus on reduction strategies through the ilioinguinal. And I think, for the remainder of this talk, you can, depending on your experience, you can substitute AIP plus a iliofemoral equivalent for a lateral approach for this. I'm going to focus on the posterior column, although DS has already seen it, so we can limit the duplication to some extent. And then I've inverted the order a bit so we can then talk about the patterns where this approach choice is no longer useful because of inaccessibility of some of the components. So I think this is a great example of being lost in translation. So this was the original description of the associated both column. I bet I read this 30 times and I could never figure it out. But ultimately, you've already seen it depicted, and this is a situation where clearly the picture is well worth more than 1,000 words. So there's no articular surface in continuity with the intact posterior nominate bone. And so if we look at the distinction between the last patterns that DS went through, the associated anterior posterior hemi-transverse components, this component can become vanishingly small, and eventually, and sometimes it will be incompletely fractured at this point, and then becomes a question of semantics, whether that transitional pattern belongs here or with the both column pattern. This is the more typical, fortunately for us, because it's technically somewhat easier to deal with, the associated both column with extension to the iliac crest, with or without a segmental anterior column component. And Emil made a big distinction between this and the next group. So in his series, it was about 23% of his fractures were associated both column, and the bulk of those 20% were fractures that extended to the crest. There are, however, variants that don't make it that far, and these are much more difficult in general to deal with. So there's one pattern here that exits at the interspinous notch. But you'll see a commonality in some of these, and the posterior column component for many of these is relatively axially oriented. And that's important as we come to addressing that later on. And then there are problematic patterns in which the caudal portion of the sacroiliac joint with a variable piece of the upper portion of the posterior column is involved. And these are things that we can't see from an anterior approach and therefore become problematic. And then there are other atypical variants. These are very unusual. This is one in which the posterior column actually carries with it a small segment of the anterior horn of the acetabulum. And these are more curiosities than routine, but we do know how to deal with them. And then lastly, we have to remember that a significant percentage of these fractures have a posterior wall component, more typically more extensive like this, with a communication to the anterior portion of the medius pillar. And these are generally, fortunately for us, relatively minimally displaced, and because of the intact labrum in small displacement, both column fractures, we have a rim held together. And if we get there early enough and we push the anterior and posterior columns back laterally, frequently we can ignore those. But this represented about 15% of Emil's series. It's been as high as 25% in other reported series. Looking at the plane radiography, we've already been through these landmarks and we need to remember them. I think it's a useful exercise still not to go directly to your 3D reconstructions, to try to teach yourself innominate osteology on the basis of the landmarks that you're going to use for the most part intraoperatively with fluoroscopy. So the distinction here is that all primary landmarks are either interrupted or displaced, or both. More subtle displacements in this one can sometimes be difficult to see. So we have our posterior wall, anterior wall disruptions, and we have the ilioscule line and iliopectineal line disruption, at least at one point. We have a displaced roof. And if we weren't sure about that, we might actually have to measure the distance from the midline to where that hip center is in its relationship to the roof. And then lastly, we can still see a teardrop, but its morphology may be different than the opposite side. And that may be different because the components of the teardrop have actually been separated, or it may purely be on a rotational basis alone. So these are the standard things that we can see. And then in this case, because of medialization of the head with the anterior and posterior columns, we can see more of the fracture pattern extending up to the iliac crest. So if we go through that exercise, and all of these will have a similar distribution. We have anterior and posterior wall disruptions. We have an ilioscule line, which we can't see, a very high disruption of the iliopectineal line, and a similar pattern for the anterior column disruption. We also see in this situation a bit of widening of the anterior aspect of the sacroiliac joint. The obturator oblique shows this. There's a disruption in the obturator frame, and it frequently doesn't show much separation between the anterior and posterior columns. And that again has to do with the fact that we have a hinge around the periphery, which is essentially holding them together. And then in this case, we can see the so-called spur sign, which is an en face view of the intact innominate bone. If we look at that again, usually seen on the obturator oblique. It doesn't really make any difference what you call this, but frequently you can see the spur sign on the AP. It may not be the same projection, but here we can see that this is an intact innominate bone. And you can actually see it on all three views, depending on the relative displacements of the components of the fracture. And then the iliac projection showing a nice depiction of the exit at the iliac crest. And in this situation, we have an intact lesser sciatic notch and an intact greater sciatic notch. We have anterior posterior walls, which are disrupted, and this is our recessed posterior wall. And so this is an atypical situation in which the posterior column has exited very cranially and taken with it a portion of the sciatic buttress. These are George Russell's labels, but it's an important reminder that, as DS already showed you, you have to start at the top and follow it all the way down. So you have the anterior column at the top, the intact innominate bone getting progressively smaller. And then we're picking up the posterior column as we get more caudal. And usually the first thing we see in these with displacements is the quadrilateral surface component of the posterior column. And then we'll follow that down further and further to the point that at this point, we almost have nothing left of the intact innominate bone. And many people, without looking very carefully at these, will look at this component, not necessarily at this level, but lower down, and think that there is a posterior wall component. And then all the way down till we get to the anterior column below the roof. Going on to 3D, this is where everybody wants to go. You'll have variable qualities based on the software and the imaging algorithms, but this again shows us that very high exit, taking with it the sciatic buttress. This has its own potential liabilities associated with its fracture pattern in relationship, in this case, to the L5 nerve root, as well as if it's a little bit lower, exiting in the greater sciatic notch, potential injury to the superior gluteal neurovascular bundle. And then the posterior aspect of that, and then the equivalent of an obturator showing the spur sign. I'm not going to spend much time on the anterior column reduction components, which you've already seen. This is based on either using, well, it will be predominantly based on the access that you have through an ilioinguinal. And this is our fracture pattern with an intercalary iliac crest component and this very important pelvic brim component, which sometimes people feel is irrelevant, but is a critical part of your anterior column reduction. The first thing you have to remember is that's your initial displacement. That's where you want to start with lateral traction, usually distal lateral traction. And you're taking advantage of the ligamentaxis component of essentially early reduction by virtue of the fact that the capsule is intact, as is the labrum, at least in small displacement or medium displacement fracture patterns. You've already seen this, I'm not going to belabor it. This is the atypical group of fractures that are articular where we never see the joint. So we're building from the periphery to the joint, and so that any very small peripheral malreduction will tend to amplify as you get closer to the joint. So you've already seen this and ways to avoid it, but it's absolutely critical that before you go any further, that you have this reduction absolutely anatomic, with or without plates or screws. The screws may be lagged or position screws depending on the obliquity. So now we go to this part which I always felt was very difficult for me to reconcile, and that we looked at indications previously. Nobody ever talked about doing a posterior column fracture from an anterior approach, and yet this has become the default option. And it has expanded historically from relatively smaller numbers. A lot in the early going, there were more sequential approaches in Lecternal series, but we found that we could actually get away with management of the posterior column from an anterior approach. So you have to learn to deal with that kind of cognitive dissonance. And the thing that allows us to do that is remembering that we have lateral traction, which is taking care of, to a large extent, the rotational deformity here. So if we can compress here and we have an axilla here, then we have an inherently stable pattern in which we can put ultimately screws that don't have to be perpendicular to the fracture and can still generate energy and compression. So this is my favorite initial clamp, since I always use the medial window as essentially an endopelvic equivalent. So a small drill hole here, and then a pointed clamp, and this is again through the medial window. Still one of my favorite maneuvers. You can use the quad clamps, and this is usually through the second window. The spanning ability to go around the psoas from the first to the second is virtually non-existent except in a really atrophic patient with no psoas bulk. You can use this asymmetric. It's really not a clamp, it's a reduction aid. It can act as a clamp because of the soft tissue support of the arms. And that is in this position. So if there is residual medial rotation, this is a very good derotational aid. And it can give you essentially a perfect reduction. And you can assess that through 2 or 3 windows. And this is the lateral portion through the interspinous notch. So you have to make a small window for the lateral arm. And then if you don't like the fact that it may be slightly posteriorly displaced, then you can judiciously place a bone hook in the lesser sciatic notch. And that will allow you to then bring the posterior column anterior as you lateralize. This is the collinear clamp, which is extremely powerful, but is not a very good manipulation aid, i.e. it can compress, but it's not very good at actually manipulating what you're compressing. And the danger here is that if you compress too much here, and what you can see, you always have to be worried about what's happening on the side opposite you, which will be a gap the more tension you generate on the quadrilateral surface. So those are the primary means of dealing with the posterior column. And this clamp is usually placed through the first window with the hip flex. It actually acts as its own retractor, as does the asymmetric clamp. It can also be placed to the second window with care. So what about the fixation? We've already talked about the orientation of the posterior column in a lot of these patterns being relatively axially rather than oblique sagittal in orientation, unlike the associated anterior-posterior hemi-transverse. So we know that our posterior screws beginning in the sciatic buttress are going to be safe. And we just have to figure out how we're going to minimize the lateral or retroacetabular gap, which we know exists, but we can't see. And so our first screw is designed to come out in this position, the retroacetabular surface. And because of this buttress effect here, because we've already fixed the innominate bone here, even though this screw is not perpendicular to the fracture, if it's loaded, it can generate some compression and it can't go anywhere because of this fixation. So that screw goes in first. And then we have to think about where else we can put screws. And DS has already shown you that a line from the SI joint to the psoas gutter essentially demarcates no man's land as far as screws that don't exit on the quadrilateral surface. So we have the head here, we have these potential screws. This we know if we're going to use it, it's going to go through the cotyloid fossa. And other than that, we're going to be dealing with oblique screw orientation. So we've had our first screw already placed. So now the second screw is this one, which is usually much longer. And since we've neutralized the lateral gap, hopefully we can make this as long as we want. And indeed, it usually comes down in the ischial spine. It can be 110 to 120 millimeters. And at that point, we've then fixed the posterior column to the anterior column, and we just have to decide whether or not this is significant. In many cases, this is low enough, it's almost extra-articular, and I would ignore it. But you can fix it after you've finished in situ plate contouring. There are a variety of ways to do this, using just simple 4.5 millimeter screwdrivers or dedicated instrumentation. So you can fix that and then do your final fixation in the pubic body. And DS has already shown you the screw. This is the location that Emil talked about, which is going through the cotyloid fossa. So you usually have your finger on the obturator neurovascular bundle as you're putting the screw in. And this is going through the fossa. It can also be moved over here and becomes in, out, in. But remember, the out part is right in the obturator canal, or the obturator canal, not the obturator frame. The canal is what's holding the neurovascular bundle. So that's a dangerous potential place to put it. It also is difficult to get back in because this is a cortical surface that can sometimes make it difficult, even after you've drilled it, to have the screw find it. And that's where it would be if it goes through the cotyloid fossa, and you have to make sure you can image that they're fully clear of the articular surface. Lastly, what do you do with the posterior wall? Progressively, we've just dealt with these from a limited, but hopefully adequate exposure of the lateral aspect of the ilium to put a clamp outside. And if we've done a really good job of reducing the columns, then the posterior wall will be minimally displaced. And sometimes we can just fix it in situ, or we can clamp it and then fix it from inside out. So what about the limitations of the fracture pattern? Well, we know that the more iliac comminution or posterior extension than it is, the more likely we are going to build in a secondary congruence. Even if our fracture planes that we're seeing look good, eventually we end up with problems of us essentially reforming the joint around the head rather than creating an anatomic construct. In situations in which the B-type or the exit of the anterior column is below the crest, these become progressively more complicated. And in cases in which there's articular comminution, even more so. And then there are occasional segmental posterior column fractures, which are very difficult to deal with from the front. And then we've seen this already, the inaccessible caudal portion of the sacroiliac joint, which provides a key component of our articular reduction sequence. And then lastly, what about the atypical, more displaced posterior wall components? The alternatives after the default iliolinguinal are the extended iliofemoral, which Mike Stover is going to talk about shortly, and then sequential approaches, typically iliolinguinal followed by a Coker-Langenbeck. And in the early days, there were some Cokers followed by iliolinguinal. And then Jeff Mast, extended iliolinguinal, we'll see one case of that, and that's the citation that you see below. I'm just going to go through what has sort of followed as far as we've expanded the indications for this. So these are relatively fuzzy volume rendered images of a both column fracture in which the cranial portion of the SI joint is involved. We can follow this through when we see the obturator oblique view. And then we can see this segmental component of the sacroiliac joint, but now this is the stable part, and this is part of our visualized field. And you can see this immediately set up for a potential lag screw fixation. And then in 3Ds, we have the very posterior extent of that component. We have a fairly typical variant of a posterior wall, and then this, again, anterior segmental component of the fracture pattern with some pelvic brim comminution to make it a little more interesting, and then some displacement of the quadrilateral surface. We've already hit that point multiple times, but the quadrilateral surface, in my mind, is useful primarily as a reduction aid. Once in a while, it's important, particularly for marginal impactions, to close the door and create a containment vehicle for elevated or depressed articular segments. But as a need for direct fixation in and of itself, it's rarely indicated. So this is the sequence. So the first thing that happens is the head is pulled back to close to its anatomic position. The sacroiliac joint is fixed after repositioning it. We can see a shank screw in the anterior column, a lag screw back into the intact component. The SI joint's been fixed. And then a sequence in which I typically use the plate as a preliminary, essentially clamp equivalent. And then secondarily, further refinement of the reduction utilizing a clamp through the plate, and then stabilization of the anterior column to the intact innominate bone, and then lastly, the posterior column fixation, using, in this case, just 2 long screws initially, and then we have this screw again, which we've seen already, which is our screw medial to the joint. In this case, this was an in-out in screw. And then about 4-year follow-up with, you can see internal iliac fossa and external HO with, again, fixation of the posterior wall component from inside out. Okay, other patterns which I don't think are always amenable to that: extended iliofemoral. Michael should go over this in great detail in a bit. This is an atypical pattern for 2 reasons. One is we have essentially an ischiopubic segment with an inferior exit in the caudal portion of the sacroiliac joint. And then we have this extended anterior column component, which exits very far posteriorly. So without this reduction being perfect, this reduction can't be perfect. And so you have an obligatory surgical secondary congruence if you're lucky. So it is a younger patient, and this was an extended iliofemoral approach. So this shows the problem as far as looking at that displacement. And this was done through an extended iliofemoral, in this case, using a bone block for the medius pillar and a trochanteric osteotomy. Results at about 2 years. Now I have to apologize for some of the imaging for this. So this is the sequential ilioinguinal Coker-Langenbeck. I think I've only done this 4 times in my career, and most of these are remote. So this is one that's hard to see on the plain X-ray, and even worse on the 3D reconstruction, since these were early. We can see this extensive anterior column component, again, very far posteriorly, a little bit of pelvic brim comminution, but the critical part of this was this segmental posterior wall component, which couldn't be addressed anteriorly. And looking at the axial cuts, we can see the separation between the anterior and posterior columns. And then we can see the beginning of this segmental posterior wall and the displacements. So this was done sequentially through an anterior approach first, and then turning them over to do a prone Coker-Langenbeck for management of this segmental posterior wall fracture. And then lastly, the extended ilioinguinal. This is, again, a pattern which we can see now. This segment is our intact innominate bone, and this is a large intercalary component of the innominate bone with the inferior or caudal portion of the sacroiliac joint, and then relatively modest displacements between the columns. In this situation, we can see that the exit point of the posterior column is actually quite low here, and here's our large intercalary component of the innominate bone, and not much displacement on the obturator. We do have these axial cuts which show this very large intercalary component, and this is our intact innominate bone, fortunately with still a stable sacroiliac joint complex. And so this is done, if you're interested, I think this is useful. I've done 6 of these in my career. They're rare, but they can be very useful. This is the posterior portion is an external iliac exposure. And then the patient is positioned in a 45-degree position. The table is carefully rotated to give you a supine iliolinguinal and a lateral approach to the ilium as well, almost lateral decubitus. So you can see the position of these screws. This is our lateral iliac exposure for this fixation, and then typical fixation for the more common both column components associated with it. So in summary, we have a wide range of fracture patterns, and they are demarcated by the pattern of anterior column extension, as well as caudal SI joint involvement, and rarely posterior wall components that are not amenable from an anterior approach. These are indirect reduction strategies that require an anatomic reconstruction from the periphery, since we never actually see the joint itself. So we start with the intercalator iliac segments, reconstruct the anterior column, and then the posterior column and the posterior wall. And the approach alternatives to the standard iliolinguinal or AIP / first window are the extended iliofemoral or sequential approaches, and rarely the extended iliolinguinal. With that, thank you very much.
Thanks, Keith. So I think we'll just carry on, and we'll ask Mike Stover to talk to us about the extended iliofemoral.
Are you seeing the?
Yeah, you're great.
Okay, so I'm going to give the discussion on the extended iliofemoral approach. I'd like to thank my long-term friends Mark Reilly and Steve Sims for some of the content in the talk. We've all given it a number of times, and I think they've all become one talk over the last few years. So the learning objectives are: why do we use the extended iliofemoral approach, its indications and contraindications. The technique specifically, we'll go over that for most of the talk. I'll give you a few examples, and we'll talk about the complications. In Letronell's book, he discussed the extended iliofemoral development was prompted by the need to have simultaneous exposure to both supporting columns of the acetabulum through a single incision. It follows a truly internervous plane between the gluteal nerves and the femoral nerve. It's based on the posterior pedicles of the superior and inferior gluteal neurovascular structures, and allows access to the joint for assessment of the reduction. So it's a very powerful approach. And really, when do we use it? When we want to obtain when we think that an anatomic reduction is judged to be probably impossible with the use of the ilioinguinal or the Coker-Langenbach or any of the other approaches developed used alone. So typically the indications are 2-column fractures, the T-shaped fracture, transtectal transverse fractures with or without a posterior wall, and associated both columns. Really the big indication also, or major indication for the extended iliofemorals, are these older fractures, all of which are 2-column fractures. And this is really when we may need the exposure into the joint to allow for assessment of the reduction. The contraindications are, of course, advanced age. I think the morbidity of the approach would be challenging to an elderly individual with the elevation of the abductors from the external iliac wing. You want to avoid performing the surgery on patients that may have a Morel Lavallee or a soft tissue degloving injury along the iliac crest or lateral hip. As we know, this may be involved or associated with a higher risk of infection. In that circumstance, you could really lose the joint quite quickly and really not have very good reconstructive options. There are some controversies regarding its use with a known injury or with a previous embolization of the superior gluteal artery. I think it has to do with how it was embolized or how it was injured, how you assess it. And Letronell discusses in his textbook, actually, that intraoperative disruption of the SGA has not necessarily been associated with severe complications. And then obesity, again, for the risks of infection is probably a contraindication. for the approach, and it's very challenging to do in the obese individuals. So typically it's in a lateral position, or always in a lateral position. I prefer to use an orthopedic table. It does allow for more efficient lateral and distal traction. You can do this through the perineal post or through a distal femoral pin. And it does help us position the femoral head into an appropriate position to reconstruct the bone around it. It also gives you the ability to visualize a little bit better in the joint with some distraction. Alternatively, though, you can just use a regular orthopedic table, radiolucent, of course, and then utilize instead just a femoral distractor across the joint as your traction device. It just doesn't give you as much efficient lateral traction. You typically have to still use a Chance pin in the femur to help pull the femoral head out. Letronel described the stages of the approach as the detachment of the origins and insertions of the hip abductors. And this gives you exposure to the iliac wing from the greater sciatic notch to the anterior superior capsule. Second step is to expose the posterior column, which is the Coker-Langenbach type of exposure of the posterior column with release and elevation of short external rotators, and exposure of the lesser sciatic notch down to the cranial ischium, and then finally doing the capsulotomy. He also described the additional exposure of the internal iliac fossa. This is utilized mainly in fractures that are older or in fractures with a transverse or T-shaped orientation. This gives you a little bit more access to the pelvic brim for reduction maneuvers, and also cleaning out the fractures with more delayed fractures. You can limit this to elevation distal to the anterior superior spine. I'll show you a little picture of that in a minute. But you can elevate the iliocapsularis and even just release the reflected head of the rectus or the direct head of the rectus. And this will give you exposure all the way over to the iliopectineal eminence down onto the quadrilateral surface for palpation reason, not visualization, but you can actually visualize the fractures as they come above the brim out to the anterior rim in the T-shape or the transverse shapes. You can release the sartorius and inguinal ligament from the anterior superior spine. Keith showed an example where you take the ASIS off with a bony block to help maybe improve the vascularity or maintain the vascularity to the anterior superior spine during that approach. Joel Matta discussed that if you do have fractures that go up to the crest, that elevation of or release of the sartorius or inguinal ligament can put at risk devascularizing this area, because this separates it from the perforators into the ilium more posteriorly. And probably you should maintain at least the rectus on and the anterior capsule on that anterior fragment if you do this with fractures that extend to the crest and a associated both column or anterior posterior hemi-transverse. But this release, I've only used it really for delayed fractures in order to help clean the area, and more commonly with a transverse segment. So here's the kind of exposure you can get with the release of the tenotomy of the rectus off the anterior inferior spine. You can still use a window up here into the internal iliac fossa for visualization if you have a fracture that goes along the iliac crest and exits highly. And with the reflected head cut here, the direct head off, you can elevate all the way down to the psoas gutter, onto the iliopectineal eminence, and you can get internal access all the way back to the greater notch and just to the edge of the pelvic brim. And if you limit your dissection back in this area, you won't disrupt those important perforators into the ilium that can result in devascularization. I like to separate the first stage, though, into three parts. That's the Smith-Peterson approach, the anterior aspect of the hip, followed by the elevation of the abductors, and then release of the abductors from the greater trochanter. And this allows you access to the posterior column. So here you can see the initial portion of the elevation. You can see we've already developed the incision over the sartorius anteriorly, and now we can start to identify the origin of the tensor fascia muscle all the way back to the gluteus. Here you can see where we have to sharply actually release the
Okay, thank you. I'll be right there.
Insertion of the gluteus maximus onto the crista glutae. which gives us better access into the greater sciatic notch. And here's the interval kind of demonstrated throughout the MRI cuts, beginning from anterior and working our way posteriorly until we're able to elevate the gluteus maximus and medius from the entire iliac crest. So then you proceed to the Smith-Peterson portion of the approach. This is probably the more confusing area for most people. If you do a lot of anterior hips or anything like that, you may be a little more familiar, but there's this overlying retinacular tissue on the anterior aspect of the hip that needs to be incised. From here, you can identify the ascending branch of the lateral femoral circumflex vessels, the reflected head of the rectus. I think it's also important to identify the anterior or cranial extension of the vastus intermedius or lateralis, as this will really help you identify the gluteus medius tendon, which has to be released as the final portion of that first step. So as you incise your way down, then you'll get an exposure like this. You'll see that the abductors are elevated. We've identified and saved the stump of the minimus. We've released the minimus. And now we prepare keeping the stump of the minimus. And in this circumstance, instead of releasing the tendon, many times what I'll do is a trochanteric osteotomy and release this more posteriorly. For me, this is a little bit easier and maybe a little bit quicker also to perform in this way rather than a tenotomy of the medius tendon. I have a little bit of trouble probably identifying that perfectly on the lateral aspect of the trochanter, and then releasing it, and the repair is a little bit more less reliable for me as far as the finishing up the approach. Finally, we're going to expose the posterior column. That just really is releasing the short rotators from the posterior aspect of the hip, elevating them off of the retroacetabular surface. As you see here, we typically do it. I'll commonly move to the other side of the table and work on the back side of the patient from this portion of the approach for the exposure and reduction of the posterior column. It's just a little bit more comfortable for me to be back in that position where we typically do the posterior approach. And that just gives us a little bit more exposure caudally, I think. And this is where I run into issues with the lateral position, because I think it's a little bit more challenging to access that very caudal portion of the approach or the cranial aspect of the ischial tuberosity, and also to get palpation access or clamp access onto the quadrilateral surface. And finally, you can do the capsulotomy. Letranel described this just peripheral rim capsulotomy for visualization of your reduction. You can be a little more extensive as long as you're not going to devascularize or detach some of the more cranial portions of the anterior column, where you can actually sublux the joint and take a look at the reduction within the inner aspect of the joint. This can be modified because you may have some wall fragments or things that you just move out of the way rather than actually doing the capsulotomy itself. So these, for me, are the difficult areas for exposure: the caudal aspect posteriorly near the ischial tuberosity. I see that a lot better through a traditional Coker-Langenbeck approach. Maybe that's just the lateral position. And then, of course, the digital aspect or digital palpation along the quadrilateral surface in the lateral approach or lateral position. So we're going to just go over a few specific fracture types and the indications that we talked about quickly at the beginning of the talk. So in both column fractures, we look at fractures that may have indications for the extended iliofemoral if they have a complex or a segmental fracture of the posterior column, and Keith showed an example of that. These displaced fracture lines that cross the sacroiliac joint are also an important fracture pattern for the extended iliofemoral. I really think this is probably the best way to anatomically reduce each of the fragments. As Keith talked about it, you can probably get away with some kind of secondary surgical congruence without the extended iliofemoral, so you may want to weigh the risks and benefits of that. Whether there's wide separation of the anterior and posterior columns at the acetabular rim or quadrilateral surface combination. Now, the importance of these are that through a single approach, you're not going to be able to control the contralateral column or the opposite column very well through the anterior or posterior approach, because we're relying on the attachments of the soft tissues or the quadrilateral surface itself to help facilitate the reduction of the opposite column. And if those things occur, whether these wide displacements are seen, you can see them at the using a CT scan right at the weight-bearing surface. If there's a wide displacement of the anterior and posterior column on the CT scan in a both column fracture, you're not going to have the soft tissue abilities to help secondarily pull that opposite column over, and then also the quadrilateral surface combination. So here's the typical example of what I use an extended iliofemoral for quite often, and probably the majority of the fractures that I've done it on. And this is a associated both column fracture. You can see the disruption of both columns through the ilioischial line, iliopectineal line. And you'll see that there's a fracture line that goes all the way up into the iliac crest. But more importantly, you'll see this little wedge-shaped fracture fragment right here. And this is what Keith was talking about earlier. Also, could be or probably is portion of the spur sign. But if you look at the Judet views, you can see here on the iliac oblique, the entirety of the greater sciatic notch is a separate fragment. And here you can see that the spur sign is actually truly a free-floating fragment on the on the obturator oblique. And so now you don't really have a key to do your typical reduction maneuvers where you're going to start from here, put this pie piece back onto here, the intact ilium, and then where are you going to set your anterior column to if you don't have this? And then finally, how are you going to get your posterior column back into position? And this CT scan might be just a little bit younger than the ones Keith showed us. That one, it had to be vintage 1970. But this one is 1990s, I think, or early 2000s at Loyola. And here's this fracture fragment that you can see right here. So as you build this now from the outside, you can see how you can piece this together in a way that will allow for anatomic reduction of the joint. So here's the typical sequence, starting way back from the intact ilium, bringing the sciatic buttress back into position, moving more forward and sequentially putting the anterior column wedge fracture back into position, and then moving even farther forward to bring the anterior column back into position, and finally using very similar techniques that we use from the posterior approach to bring the posterior column into position. Now, the difference is from the lateral aspect of the ilium, there's different screw trajectories. We use these commonly even with just percutaneous techniques for the pelvic ring, or also for acetabular fractures. And so all these are readily available through the lateral aspect of the ilium utilizing the extended iliofemoral approach. So here's our postoperative x-ray, and I think you can see where the reconstruction of the greater sciatic notch is, and the typical reconstruction with screws and plates. I typically will use plates along the iliac crest of the wedge fracture fragment too, because I'm going to rely on these fragments here to pull the anterior column back into position. So I'm a little bit concerned if I had just a lag screw holding the wedge fracture that I'm placing a clamp onto to bring the entire anterior column back into position. So it's not unusual for me to use some plates along the iliac crest in that situation. And here's what we commonly see is a little bit of heterotopic ossification. Now, how about transverse fractures? Typically, they should be transtectal transverse, so the importance is that these fractures go right through the weight-bearing surface. And we start to lose control of that ischiopubic segment, or the lower half or free segment, if there's an ipsilateral or the contralateral rami fractures or a symphysis disruption. And sometimes we won't control the cranial intact portion if they have an ipsilateral SI joint injury. And especially if you have central dome impaction, that might be very hard to get to if you don't have an associated posterior wall fracture. So this is what we're demonstrating. Commonly, we like to have this intact symphysis because now we have a rotational control of the anterior or the opposite column through the transverse, and also allows us to control the rotation along the horizontal axis. So here's a case example. You can see here, you can barely see a loss of congruence of the joint. Here's a fracture through both columns, through the ilioischial line, iliopectineal line. It looks like a rather low fracture on this image, but you can see that there's also contralateral rami fractures and the symphysis dislocation. And if you look at this more closely now on each of the views, This comes in right underneath the anterior inferior spine. So it's a high roof arc angle, anteriorly and posteriorly, with the subluxation along the posterior column. So you also can see the symphyseal dislocation on the inlet outlet views. And now you get this this picture of the orientation of the fracture right through the weight-bearing surface, a very high transtectal transverse. Now, some believe that you can reduce this through an anterior approach, and I think you can control the cranial portion of the transtectal transverse, but it's very hard to close down the more caudal portion without leaving a gap due to your clamp placement within the internal iliac fossa. So in this circumstance, you can use the extended iliofemoral. You can use clamps from the front and from the back and control the caudal portion, even in a T-shaped type of fracture. And then using the screws into the anterior column and plates along the posterior column to help control that. So here's our postoperative x-ray. You can see there are imperfections in the pelvic ring. So the acetabulum takes precedence, of course, so that we're going to reconstruct the acetabulum, put that back together through the extended iliofemoral. Then she's put in a supine position, and we secondarily plate the symphysis to allow for stabilization of the pelvic ring. And here she is actually 12 years post-op with a functional joint. Transverse post-posterior wall. These are the same indications as the transverse with the contralateral injuries or loss of control of the ischiopubic segment, but also the posterior wall fracture component is important, is that if it's extended or beyond the posterior border of the bone, as you can see here, it comes all the way and passes the posterior border of the bone. Now you don't really have a posterior read for a Coker-Langenbach approach. So you're either left with an anterior approach to reduce and stabilize the anterior portion of the transverse, followed by a sequential posterior approach, or the extended iliofemoral. Also, a cranial extension is difficult through the Coker-Langenbach. This can be dealt with a greater trochanteric osteotomy, or again, working through a single approach in order to perform the reduction and fixation, especially if there's some associated impaction through the cranial aspect of the joint. So here's an example. This gentleman's in a high-speed motor vehicle crash, had associated dislocation, transtectal transverse. You can see here, even on the plane radiographs, he's got central dome impaction and a very complex multifragmentary posterior wall. So here's his axial cuts through his CT. You can see the impaction through here, the complexity of the fracture pattern as it goes through the transverse and the multifragmentary posterior wall, and the CT demonstrating the same. So due to the cranial impaction and the transtectal transverse, we did this also through an extended iliofemoral, and this is a post-operative x-ray, and these are 7 years post-op, so he does have some grade 2 heterotopic ossification, a nice functioning joint, but probably some loss of congruence over the years. The T-shaped fracture, again, transtectal transverse components, wide displacement of the vertical stem of the T can be an indication, again, because you're going to have difficulty controlling the opposite side of the fracture through a single approach. And also if they have the associated dislocations around the pelvic ring, this may be an indication. So here's a very good example of Mark Reilly's. This is a symphyseal dislocation, SI joint dislocations bilaterally, a wide displacement of the vertical stem of the T. Here's the anterior column component, the posterior column component, both of which are transtectal. And so this would be a good indication to proceed through the same type of approach to the fractures we just demonstrated with the transverse. And then finally, delayed fractures. I think this is important for the interarticular access because you can confirm the reduction along the cartilage borders, because you're going to have a resorption of the fracture lines that begin with the maturation of the callus, and you're also going to have a hard time mobilizing the fracture fragments, especially in relatively young individuals who are going to have a lot of bone healing within the first 21 days. So this is an example of a delayed fracture pattern. This gentleman was involved in a high-speed motor vehicle crash. He seemed to like methamphetamine, but he had this high energy injury. And here's his sciatic buttress right here. Here's his anterior column. You can see that the posterior column component is also displaced, and he's also got a small wall component on the AP. So he underwent initial embolization at the outside facility. And due to the embolization, he underwent a intrapelvic approach along with a lateral window. He showed up at our institution 4 weeks post-op. These are his initial x-rays. He's non-congruent. He's 18 years old. And so I felt that this was probably a joint that could be salvaged. The CT scans show that the residual displacement was through the posterior column and likely due to secondary positioning or malposition of that sciatic buttress fragment. So we took him to the operating room, removed his implants through the ilioinguinal, staged this a week later after healing with an extended iliofemoral. Here's his intraoperative imaging, his initial post-op imaging. You can see now his femoral head is congruent. Here's the incisions that we utilized in order to perform this surgery. And here he is now at 2 years out. Probably has a dead piece of the sciatic buttress up here in that he has a non-union of the posterior column, but he is asymptomatic. He has no pain, functioning at a very high level. And so he decided not to do anything about this at this point in time. So you can see the power of the extended iliofemoral approach and its ability to obtain excellent reductions in patients with very difficult fracture patterns, but at what cost? And I think the most common complication, not I think, but we know that the most common complication with the extended iliofemoral approach is heterotopic ossification. Letronel showed, and other papers have shown, that high-grade heterotopic ossification formation, the reduction in risk can be, there can be a risk reduction, especially with the use of indomethacin, with or without the use of radiation. You just have to choose whether or not you think that the radiation fits the risk profile for the patient. Infections have not been that common in Letronel's book, and in my practice, my very first patient was infected. I've done only 16 of these in my practice in 20 years of practice, so they're not that common. But if you do have an infection, it's disastrous. It's a very difficult and challenging reconstruction. You're probably left with arthrodesis as your bailout. Skin necrosis has not been a problem, but has been reported. And these last three are typical for probably just a little bit of mishandling of the soft tissues, where you can end up with neurologic injuries, skin issues, and or vascular injuries. And in Letronel's discussion in his book also, intraoperative disruption of the superior gluteal artery in 4 cases did not result in a massive slough of the flap. And therefore, it's uncertain what the importance is of that, but there have been case reports also of major sloughs of the abductor flap. So preoperatively, you may want to judge whether or not the patient has an intact superior gluteal artery, and that has been described in the literature as well. And preoperative angio may be indicated in that situation. So in summary, it is reserved for many of the most difficult fracture patterns that we encounter. It can be a technically demanding approach, but I think you do it a couple of times on a cadaver and you have good mentors that can help you. It is an approach that's very important and can be done very safely in most circumstances. It does have the highest overall complication rate, though, of all approaches to the acetabulum, but it's still a very important approach to provide comprehensive treatment of acetabular fractures in a practice. So thank you very much.
Thanks, Mike. One of the questions that came up relates to total hip arthroplasty after an extended iliofemoral, as far as concerns, contraindications, or.
Yeah, I've had the opportunity to do a total hip on a young lady that we did an extended iliofemoral on, and that's the only one so far that I've done. And we just went through a extended Smith-Peet approach, took out some of the hardware that was in the way and performed it in that manner through a extended Smith-Peet anterior approach total hip.
Okay, great. Thanks a lot. Excellent. Okay, so last speaker will be Dr. John Eastman from UC Davis, Sacramento. He'll be talking to us about the management principles of concurrent combined pelvic ring injuries and acetabular fractures. John.
Thanks, DS. And we'll try to wrap up today's session with this, and I think it's a very daunting task just because I've just seen the amount of details that's going within each topic within pelvic ring and acetabular fractures. Now we're going to try to combine them into both injuries at the same time. And so I want to start with our patient here that we'll come back to at the end. And I'm just going to tell you, he has a left-sided transverse posterior wall, a juxtatectal or a truxtatectal, maybe transverse at the very peripheral margin, but then a complete symphysis pubis and then a right-sided sacroiliac joint injury. And so just take 20, 30 seconds and think about how we're going to get a reduction for each of these injuries. What's the sequence in terms of which injury is going to be addressed first? What are the possibilities or problems with doing one versus the other before each one? And so we just start posteriorly, start with the symphysis, start with the acetabulum. Are you prone? Are you supine? I think a lot of different ways to start addressing this patient. And so we're going to get into them. And so objectives, I just want to briefly cover and just hit home the point of the variety of the injuries that are out there and really the importance of understanding each injury and why that comes into play. And then just to begin to recognize the potential treatment strategies and why we may pick one versus the other. And so I think just like everything in life, the spectrum of injuries is there. And here's two extremes. The left is a very minimally displaced transverse with an ipsilateral sacroiliac joint. And then obviously on the right, you can see a more impressive complete pelvic ring disruption with a symphysis and a transverse and a sacroiliac joint as well. And so again, those are going to be treated as entirely two different injuries. You can see the resultant reconstructions. And so again, opposite ends of the spectrum with much different treatment strategies. And so I think the main problem is that when everyone thinks about these, they want the direct way of how to deal with it every single time. And the truth is we don't have that Bible or that manual. We don't have an algorithm that's applicable to every single injury. In the literature that we can see, if you do a PubMed search, you can see it here, is that there's 40 or so results pop up, but really the ones that come into play that really take a look into them are listed here. But even then it's challenging because you can see the variety of these injuries that come into play. And so it really makes doing meaningful research that has comparing apples to apples is incredibly difficult. And so what we take from those studies is that the incidence of these injuries is fairly low, anywhere from 5 to 50%. The pelvic ring component is about the same in terms of anterior-posterior injuries versus lateral compression injuries. In terms of acetabular fractures, we can see that the transverse, the T-shape, and the associated both column are all fairly common, and the posterior wall tends to be not as common. And why that is maybe towards the pathomechanics, which in and of itself is not so clearly understood. But you can see there's some sort of typical lateral injury vector in terms of the acetabulum, but also some sort of external rotation force of the pelvic ring. And I think ultimately all these fall into some sort of a combined mechanism to try to explain how these occur. But we do know that they occur from a high energy mechanism for most of these patients. And so accompanying with that, you're going to see patients with a higher ISS score that goes along with increased early transfusion rates and a lower systolic blood pressure when they present to the emergency department. And that comes into play in terms of resuscitation, but ultimately thinking about timing for these patients and how that's going to dictate when you can start their treatment, what positions they may or may not tolerate, and then the surgical approach. We just heard again from Dr. Stover why this may come into play in terms of when you have to do or escalate to a different surgical approach. And so defining and understanding the injury, I think, again, like everything we've talked about so far in this course, this is incredibly important. And so each of us, I think, has our own way of systematically going over each image, starting with radiographs, going through the axial and reconstructions on the CT, and finally with the 3D reconstructions. And I ask everyone to develop their own to make sure they're not going to miss any sort of those details. I will say it's easy to focus on the acetabular fracture itself, just because I think we all recognize that takes precedence in some of these injuries. But don't overlook any sort of the subtle injuries that we can often find. And I think Dr. Adams, in the first lecture of this course, gave a good look at evaluating the pelvic ring. And you can see here, don't overlook the subtle injuries. And so here's a patient with a femoral neck, a left anterior column, and a left-sided sacroiliac joint that's very apparent on his injury AP pelvis on the left. But in a quick study of his CT, you can see that he has some subtle air densities there on the right. And again, as that patient goes to the OR, you can see his right-sided sacroiliac joint is clearly unstable. And so again, that's been described in terms of being reduced either in a sheet or a binder, or also within the CT scanner itself. And so looking for these subtle injuries will be important in terms of sequencing, and we'll see that shortly. Very similarly, I think the contralateral sacroiliac joint, sometimes with a pelvic ring injury, can also be overlooked. And here's a patient with an LC1 variant injury that we can see with a right-sided sacral fracture, then some contralateral rami fractures anteriorly. But again, a thorough study of the CT will just show a couple cuts with a small avulsion fracture seen there on the left, but really no evidence of instability there. But with placement of a transsacral style screw, you can see that the joint gets pushed off. And again, this is described recently by Dr. Moffrey and all, showing roughly about a 10% incidence of these in polytraumatized patients. And so again, we'll see that these comes into play in terms of the summation of malreductions phenomenon that we can appreciate as it terms to building back the entire pelvic ring. And so again, that has to be dealt with appropriately. But getting into potential combinations of what we can have any sort of acetabular fracture with either an isolated anterior pelvic ring injury, an isolated posterior pelvic ring injury, and then again, an anterior and a posterior pelvic ring injury. And we'll go through examples of each of these. And I think starting to talk about reconstruction, I think classically the golden rule by Letournel was to always begin the reconstruction posteriorly. And just like the associated both column, the reasoning was that you're going to have a stable base to build back to. And so if you recreate the posterior aspect of the posterior pelvic ring, you now have something stable to anatomically reduce both the acetabulum and then the anterior pelvic ring back into space appropriately. The problem is, though, that reduction has to be anatomic. And so if anything is off in terms of the reduction posteriorly, as you work more progressively forward, that malreduction gets exaggerated to the point where it will be unacceptable. And so when the posterior pelvic ring is off and there's no other anterior pelvic ring injury, there's no other source of mobility. And so the acetabulum being in the middle is going to suffer the consequence of that. In a great example here, we can see a transtectal transverse posterior wall with an ipsilateral sacroiliac joint injury, as demonstrated by these select cuts. And you can see here's the postoperative AP pelvis. But what you can see is that, again, there's incongruities both of the sacroiliac joint and then the symphysis. But if you look closely there, you can see a residual gap in the transtectal component of the transverse. And so the postoperative CT scan shows that. So the incomplete reduction of the sacroiliac joint forces the summation of malreduction concept so that the acetabulum cannot move in space. And so it's left with a gap. And so understanding these injuries is going to be the key mark of this. And so I would advocate for really considering each injury separately and to understand it in detail. And once you have that detailed understanding, you're going to be able to decide what's the appropriate operative approach for either both through a single incision or a surgical approach, which is ideal. But again, it may be necessary for a stage or sequential approach. But again, I think the concept that everyone does agree with is that the acetabular reduction does take precedence. And so I think it's a little bit of a heresy to talk about form fractures in this setting, but I do think the point is that it's not always done the same way. Just like form fractures aren't. It's not always fix the radius first or always fix the ulna first. I think you take into consideration the injury details of each, and that's going to tell you which one to start with and why. Because you will get ligamentaxis, and it'll help your further reductions. But again, if you have a malreduction of one, you're almost guaranteed to have a malreduction of the other. And so going through our injuries, we're going to see just 4 brief examples of some combined injuries that we can see here. And the anterior pelvic ring component, it can be ipsilateral, it can be contralateral, but oftentimes that's kind of an afterthought in terms of the reconstruction. And sometimes it will be addressed if there's residual instability in terms of the pelvic ring component, much like we do with the pelvic ring injury, it's in isolation. But rarely is that addressed as a first component to set up some sort of ligament metaxis or indirect reduction of the acetabular fracture. And so sometimes they are addressed as a last component or sometimes left alone without any reduction or fixation, as they'll get an indirect reduction from the complete restoration of the pelvic ring itself, but rarely is it first. The posterior pelvic ring injury, we've seen some examples. Here's a 23-year-old with a left-sided associated both column acetabular fracture, and then a left-sided sacral fracture that we can see here on just one select cut. But here, in terms of considering staged or which injury to think about first, I think in assessing this patient's overall pelvic ring and acetabular injury, her overall pelvic ring alignment was relatively maintained. And so starting posteriorly first works here in terms of in situ stabilization of the posterior pelvic ring and the sacral fracture. That way, we will have an intact ilium with stabilization of the ilium onto the sacrum back to the axial skeleton. And therefore, once that's stabilized sufficiently with multiple points of fixation, we now have an intact ilium to begin the reconstruction that we heard from Dr. MAYO. And so here, just select cuts working through an ilioinguinal. And here's this patient's final post-operative imaging. We can see here with an acceptable result in terms of restoration of the pelvic ring and the acetabular fracture with safe implants and I think an acceptable reduction. And so another example of associated both column, this time with the left-sided sacroiliac joint injury that's fairly apparent there on the injury films. This time, again, we can appreciate the subtleties of everything we're looking for in terms of the articular injury. And here shown with the 3D surface rendered images. But here, we're going to be doing most likely a formal ilioinguinal. And so through that lateral window, we're going to have an open approach to that posterior pelvic ring. And so again, restoring our intact ilium to give us a base to build back to will give us a platform to begin the successful restoration of her acetabular fracture. And so here, through the lateral window, we can do a screw-based reduction, direct reduction of the posterior pelvic ring that sets up a formal ilioinguinal back into a stable base, and again, clamp application with Shan's pins and K-wires to restore each segment back into position, and then final radiograph show restoration of her fracture. With again, safe implants and an acceptable reduction. And then lastly, I think these are the ones that give a lot of us the most concern, because there really, again, is no way to deal with it each and every time. And I think the most controversy comes here. And I love hearing different thoughts, because there really sometimes is no correct way or one way to do it. And you can achieve this in multiple different methods. But this is our patient again. And so, again, it's 3 different sites of injury with the left transverse posterior wall, the symphysis pubis, and then the contralateral sacroiliac joint. And so he's a rather large human. He's about 6'8", 300 pounds, and he laid down his motorcycle into a field. And so he has a bunch of abrasions onto his right side. And so it kind of steered our path in terms of maybe not considering doing or trying to avoid an open approach as much as we could on the right side. And so for him, we started thinking about his acetabular fracture as the more important injury if we could stay away from his right-sided sacroiliac joint, again, which you can see here, and just some select cuts. And so we started with an anterior approach through an anterior intrapelvic as well as the middle window of a formal ilioinguinal. And you can see here reduction and fixation of the acetabular fracture occurred first with direct manipulation and then modified reduction clamp with initial K-wire fixation, followed by an integrated anterior column screw, and then an intrapelvic buttress to set up the initial reduction fixation of the transverse. Now, with his displaced pelvic ring, I didn't want to really put a lot of direct pressure through the symphysis. And so I opted for taking bilateral AIIS Shands pins that you can see here to facilitate reduction of the pelvic ring. And so here you can see both the external fixator frame reduction, seeing the amount of torque that was needed to reduce the SI joint, and then direct reduction of the symphysis with just some fine tuning with some screw-based clamps. And that's our initial reduction you can see there, followed by plate stabilization anteriorly, and then subsequent posterior pelvic ring percutaneous fixation for a sacroiliac joint as demonstrated here. And then because of the posterior wall component, he did get a stage Coker-Langenbeck, but here's his final post-operative films. Again, with restoration of his global pelvic ring, and then I think, again, safe implants and an acceptable acetabular fracture reduction in all parts. And so I think, again, we've seen a lot of examples, and just to briefly demonstrate the wide range of injuries that exist, I think the key is to really understand each injury as a separate entity. And then once you have that detailed understanding, you can conceptualize and come up with an individual treatment plan for that patient. I think always starting to consider posteriorly is appropriate, realizing that if that injury is not anatomically reduced, you're going to potentially have a summation of malreductions. And so, again, we're always striving for an anatomic reduction with the acetabular fracture taking precedence, but starting with the injury you can make perfect makes a lot of sense. Thank you.
Thanks, John. That's excellent. So we heard last week about the anterior intrapelvic approach from Dr. Saji, and he stressed that it's not better or worse compared to the ilioinguinal, and they both have their advantages. And I think that he showed us that the AIP gives improved access to the posterior column with development of the approach from the quadrilateral surface, from the pelvic brim posteriorly. And he also showed that adding the anterior superior iliac spine osteotomy to the lateral window improves the exposure for the internal iliac fossa in the anterior wall. Dr. Mayo talked to us about the ilioinguinal approach, and it's important to have a good understanding of the ilioinguinal approach with the 3 and 4 windows. So the 4th window being the anterior intrapelvic type approach. Important for the anterior family fractures, but also can be used in exceptional cases for the transverse and T-shaped fractures. And all 3 windows, if not 4 windows, should be mastered and are useful depending on the fracture pattern. And then operating room logistics with regards to either using a specialty fracture table or using a radiolucent flat top table. We heard from Dr. Williams this morning concerning the radiology, the decision-making and the treatment for anterior wall and column fractures with techniques after understanding the fracture patterns with techniques of the anterior approach, and then lag screw concept and the sequential approach working peripherally towards the joint itself. I talked about the anterior plus posterior hemi-transverse, looking at the specific radiology and the disruption in the vast majority of cases of 5 out of the 6 lines of the Turnell, understanding and dealing with the impaction and the quadrilateral surface and the decision making. And we'll hear from Dr. Kreter in 2 weeks concerning some of the very rare cases that you may consider in a primary total hip, and then the treatment and the importance of repositioning the femoral head under the intact dome, and then dealing with the impaction and then buttressing not only the anterior wall column, but also the quadrilateral surface. Dr. Mayo talked to us about the associated both column today, looking at the wide range of fracture patterns in this group, looking at the characteristic findings of the associated both column and the quote unquote spur sign that you see, really distinguishing this from the anterior column and the anterior posterior hemi-transverse, and then doing a reconstruction of the fracture fragments working peripherally, and then an indirect joint reduction requires an anatomic reduction of the periphery. And then finally, in some instances, sequential or alternatives such as the extended iliofemoral, which we heard from Mike Stover, looking at the indications and the complex fracture patterns as he showed very well, and delayed cases, the keys to approach. And I would encourage you to, again, look at this on the video and the potential complications, the potential for muscle necrosis, including those cases that have had embolization, which may be a relative contraindication of this approach, wound healing and heterotopic ossification. And finally, an excellent talk from John EASTMAN talking about concurrent or combined pelvic ring and acetabular fractures, looking at the wide range of injury patterns that we have, achieving a detailed understanding of the injury, individualizing the treatment plan, and considering in a large percentage of cases, starting with stabilization of the posterior pelvic ring and then working through the acetabulum, and finally dealing with the anterior ring if you need to, and striving for anatomic reduction. So our homework assignment to you this week will be reviewing the prior surgical approach videos and the prior session lectures. Again, these are available on AO Trauma North America through the YouTube channel, and a link of the recording will be sent out through the Zoom contact 24 hours after the conclusion of this webinar. And then next week will be case presentations from the faculty, complex cases, and we have an additional session on August 27th. You'll be sent a link, a registration link that you have to do separately with regards to this session. This will be on a Thursday night, August 27th. And then finally, the last session will be special problems, and we'll have the pleasure of listening to special presentations from Dr. Mayo and Johnson with this last session of this virtual course. So with that in mind, I'd like to thank you all for your attention. If there's any questions, Dr. Sims, any final questions or?
No, I think that's it, Dave. Excellent job.
Okay, take care, everybody. And then just before you go, please answer the evaluation questions for this session. It will only take a couple of minutes before you sign off. Thank you very much again for your attention.